Hello, everyone, and welcome. Happy World Mental Health Day. I'm very excited to be here with you today. My name is Leslie Friday, and I'm with the Marketing and Communications team. We have a wonderful panel here of experts for our conversation, Mental Health Matters, a Global Approach to Care. Welcome, everyone, and a little bit of housekeeping notes before we dive into our great conversation. This is a Zoom webinar, so many of you may be familiar with how this all works, but as we're watching the presentation, you can adjust the width. If you look at the right-hand side of the presentation, there's a panel there that you can move left and right to increase the screen. We will be recording this presentation, so if you want to share it with others, if you can't make the entire thing, you will know that you can find it later and it will be emailed to everyone who's RSVP'd. We will be saving a portion of the conversation toward the end for a question and answer session. So if you have questions, please feel free to submit them in the chat bar. There's also an option at the bottom. You'll see the chat as well as show captions. So you can click that and have live captioning at the same time. All right, I think that is it. With no further ado, I'd love to introduce our panelists. We have Dr. Giuseppe Beppi Raviola. We usually call you Beppi, so I'm going to stick with that. And we have Dr. Stephanie Smith. Thank you both. You are the PIH Mental Health Program co-directors. And alongside Stephanie and Beppi, we have Carmen Contreras. She's with Socios En Salud, Socios En Salud's mental health director. And Socios En Salud is the Spanish translation of Partners in Health in Peru. Thank you for being here, Carmen. And we have Chenjezo Gonani, and he is with us from PIH-Sierra Leone as the Mental Health Program Manager. Thank you, everyone, for being here. I'm really excited to dive into this conversation. It really is a critical topic. And so we'll dive right in. We have some questions for everyone and some panels and images to share, which is always nice. I think what would be very helpful, first off, is to talk about the big picture and what is the current situation of global mental health that we face. And I know, Stephanie, I'd love to pose this question to you, but just knowing that depression, anxiety, and mental health conditions are rising, yet funding and the quantity of mental health professionals has not met that. So can you provide us a bit of a context on the state of mental health care globally?
Yeah, thanks, Leslie. Mental health care really does unfortunately still remain kind of at the margin within the field of global health. As you mentioned, mental health disorders are some of the leading causes of disability around the world. Around 1 in 8 people or so are living with a mental health condition, but governments tend to spend less than 1 or 2% of their budgets on mental health services. And mental health really receives the least amount of funding of all global health areas in terms of development assistance. And there are enormous human resource limitations in terms of skilled mental health providers around the world, including the whole range of providers from psychiatrists to psychologists and social workers and other mental health clinicians and professionals. And so the vast majority of people who are living with mental disorders, particularly in resource-limited settings, get essentially no treatment at all. But even like here in the US, in the richest countries of the world, fewer than half of people who need mental health treatment or support receive it. So there's clearly significant inequities everywhere for people living with mental health conditions in terms of their access to good quality, effective care, which could alleviate their suffering. I mean, I can imagine that many of you out there or your family members have struggled to navigate the mental health care system in this country. And even an insider like myself as a psychiatrist, I look at the system and wonder, how can people get their needs effectively met given the system challenges? And then you move further upstream, and there are tremendous inequities in the social determinants of health and mental health, which lead to poor mental health outcomes for certain subsets of the population across all settings, like poverty and income inequality and discrimination and other forms of social exclusion, adverse childhood experiences, and others. And during the COVID-19 pandemic, these problems were exacerbated even more. The rates of depression and anxiety, as you mentioned, Leslie, went up by 25% or more in a lot of settings. And now you see these ongoing consequences like prolonged economic problems, health worker burnout, the worsening of pre-existing conditions and disruptions in children's education, climate change, which all continue to this day. And so it's pretty daunting, but it's critical to imagine how can we address these enormous burdens, and how can we dismantle social injustice and build what is really needed to achieve equity in mental health care.
Thank you so much for setting that stage, Stephanie. And that I guess leads into the next question, which I'd love, Pepe, for you to address is, given the enormity of the situation, how has PIH acknowledged and responded to this in the countries where we're working?
Thanks, Stephanie and Leslie. And, really we aspire to a balance between a clinical approach and a public health approach. Really mental health should be seen as a continuum from well-being to distress to the development of illness. And we should be developing public health systems to really move mental health out of the health sector. And we need this in all countries, including the United States. However, because of the way Partners in Health is positioned to support facilities and to strengthen health systems, we tend to see people in acute distress, which is why the clinical approach is sort of a fundamental pillar of our approach. And so just to be very concrete, you're going to hear from Carmen Contreras and Grant Gonani, leaders from Peru and Sierra Leone, respectively. But across all of our sites, whether it's Haiti or Chiapas, Mexico, Malawi, Lesotho, Liberia, Kazakhstan, Navajo, and also we have programs in Massachusetts, actually. Sort of the core of our work is a continuum of clinical care, which includes complete mental health assessment, including medical and psychosocial assessment, psychoeducation for people experiencing mental health problems and their families, psychosocial interventions that address social and psychosocial stressors as they relate to all mental health conditions, and brief psychotherapies. We have programs focused on rehabilitation for people living with more serious mental illness. We provide medication management across all conditions and psychotherapy for more complex, common mental disorders. We provide home-based monitoring and follow-up, and we engage community health workers working from like primary healthcare center level to provide that kind of support. And so we refer to all kinds of community-based support. And then we also refer and provide material support, transportation assistance and food packages as needed. And then we also collaborate with specialists, whether they're psychiatrists, psychologists, social workers, depending on what's available in the context. So there's direct clinical care and support, but kind of the bread and butter of what Partners in Health does in mental health is really about accompaniment and various levels of accompaniment. In some settings where we work, there have been no other mental health services. So we do and have provided direct care, but what we aspire to is really having that direct care delivered within the public sector and government-run services, and that's the bulk of what we do. But we also mentor and support frontline providers working in the public sector. So we have mentors who support clinical supervision. For example, in rural Rwanda, we support government nurses in delivering direct care for serious mental illness and common mental disorders. We also work with local national trainees and physicians. So, for example, we support a clinical clerkship in psychiatry at the University of Global Health Equity in Rwanda. We also support a psychiatry residency training program in Sierra Leone, where there's one psychiatrist. We have 7 residents working at the oldest psychiatric hospital in sub-Saharan Africa. We also support kind of bi-directional training, and Dr. Smith and I work at Mass General Hospital and Brigham and Women's Hospital, respectively. So we also develop partnerships, and we also support career development in mental health care delivery everywhere we work. And we even have fellowships in global mental health delivery that we support as well. And so the goal is to strengthen a continuum of care from public sector hospitals to primary care clinics to households. And back to where I started, we also support a public health approach and moving mental health out of health systems. So in Massachusetts, we have a project with the Blue Cross Blue Shield Foundation and a mobile health unit called the Family Van, training community-based organizations, community health workers, engaging in support. We use a 5-session intervention package that uses 4 strategies, including relaxation, problem solving, giving hope, and mobilizing people to act in ways that promote their mental health and strengthen social support. So these are more public health oriented psychosocial approaches that really we should be using in the US. The US has the highest number of natural disasters of any country in the world. Very relevant the past couple of weeks, but it seems like it's relevant every month. So we also should be working to strengthen community resilience across all settings. And so we look to also apply our learnings from global mental health delivery to the US. Thanks a lot.
Thank you, Beppy. And I think, this is something that we have clearly been working on in many different ways from top to bottom. And I'm wondering if, in the 10 years that I have been here at Partners in Health, I've seen such growth and change. I wonder if you can share, maybe Beppy and Stephanie, some of the highlights of results you've seen so far, even if it's an anecdote or other information about that change that you're feeling and seeing across all of our programs.
Yeah. The past 4 years, we've had more than 250,000 patient visits across our sites. In Rwanda in 2022, we had 62,000 patient visits. And currently in one district in Rwanda, we have almost 3,000 people receiving psychotherapy from public sector government nurses at rural health centers. And so just in terms of our direct impact, that's important. But also, Stephanie mentioned the budgetary constraints. And so whether it's the US, where we have 50,000 psychiatrists, by the way, and 40% of people in an acute psychiatric crisis can't get an evaluation, or whether it's in Lesotho, where there's 0 psychiatrists, or Sierra Leone, where there's 1 psychiatrist, or Liberia, where there's 1 psychiatrist, there is a need to translate these models of care into action. And so part of that involves funding and other aspects. But what's been fantastic is that we have momentum and we're just gaining in our learning and our experience. And we're actually able to translate that experience to the US as well. Stephanie, what about you?
Yeah, I would say in addition to the enormous effect on, the numbers of people we've served and improvements in mental health outcomes, importantly, we have had, providing mental health care has had an effect on structural inequities and economic outcomes. So we have some data that show significant improvements in the number of people who can work after treatment as opposed to before, and people's families don't need to leave income generating work as often to take care of the person. And so addressing the social determinants of mental health in that way, reducing poverty and reducing discrimination really is also a preventive effort and public health effort as well. So it's kind of this, not as much a continuum, but perhaps circular and feeds back on itself. So I think we have seen a lot of those kind of economic and other types of benefits outside of just the reduction of distress and improvement in individual functioning.
Thank you. I think one thing too to plug in that I think we're all proud of is caring for the caregivers in our team and the staff wellness program that you all have started, which is so important, right? Of course, tending to patients and families, but also ourselves, right? And so with that, I want to turn to Carmen here in Socios En Salud. And just so much exciting work going on globally, but really we want to share some of the highlights from Peru. And first off, I think, we could talk about the Casas Protegidas, or the safe houses, if you don't mind, Carmen. And these safe houses for women, at least initially living with schizophrenia, is one initiative that Socios launched. And the Ministry of Health later adopted and expanded.
Yeah.
So can you tell us about how that need was identified and the difference it's making?
Thank you, Leslie. Yeah, I want to share that close to 8 years ago, I think so. Yeah, 8 years, Partners in Health Peru began collaborating with the Minister of Health for the implementation of Safe House. For example, in the next picture, the next please, we can see how this community-based program has supported people with chronic mental disorder. In this safe house was only women with chronic mental disorder who are in situation of abandonment. And we included to them in a rehabilitation system with community health workers, similar to our home. In the next slide, we can see the guidelines that the Ministry of Health provide then to all the country. And there was only one safe house 8 years ago, but now the Minister of Health is expanding to nearly 100 across all the country. And in the next slide, I want to additionally mention that we identify many people with chronic mental disorder, but who are living into the community. They are not abandoned, but who don't complete their treatment and health center, sometimes due to stigma and discrimination. 4 years ago, we began a new initiative to support families in the community who have one member with schizophrenia. In the next slide, you can see that we start only with 120 people with schizophrenia, then 300, and now we are working with nearly 1,000 families. And for this program, we have only 5 psychologists, but I have 75 community health workers who visit families twice a week to ensure the patient adherence to the treatment, identify any adverse events, or provide social support if it is necessary. Additionally, together with the team from Partners in Health Liberia and Partners in Health Boston, we are working to provide an adapted community-based psychosocial rehabilitation training program. We have completed this curriculum called Yo Si Puedo, I Can Do It, with close 100 people living with schizophrenia and their caregiver, teaching social skills and promote human rights and autonomy. Participants finished 10 sessions in 12 weeks. As a result, participants have stated they feel that they can live with the illness and be stronger together.
Thank you so much, Carmen. And I know one other aspect that I'm really impressed by is tuberculosis work in Peru. And I know that from the very early days, right, of our work in tuberculosis, we realized that an essential part of that care had to be mental health. So why is mental health care so important for successful treatment in this case? It might not seem evident to some of our listeners.
Yeah. About tuberculosis, as we know, tuberculosis is a disease that requires a long time to cure, sometimes 6 months, sometimes 12 months. Now with new treatments, it's much better, but it's a long time that the people needs to be for the cure. But taking the treatment and overcoming the side effects is very challenging for people with tuberculosis. And it also affects their self-esteem, causing stress, anxiety, and sometimes depression. That is why we provide emotional support to individuals going through this illness, the tuberculosis, to reduce the emotional impact during the treatment. In those pictures, we can show how we can provide the emotional support into the communities. And the strategy started with a small intervention. And today, thanks to the Global Fund project, we have conducted mental health screening for over 30,000 people that are living with TB and HIV. And we find that between 25 to 30% of people with tuberculosis, they are emotional problems, but we provide them intervention, emotional intervention, and in some case, we are referring to the Minister of Health for more specialist care.
Thank you. And I believe the next slide too is talking about our interventions with mothers, right?
Yeah.
And I think many people listening and watching could understand that motherhood is a joy and a privilege, but also sometimes it can cause some distress. And so would you mind talking about some of the programs that Socios is working on in this area?
Yeah, we are working in one intervention. They call it is Thinking Healthy. We identified that the mother is having more depression than the general population. And we began an intervention, and we provide to the mother and her baby for 40 months the intervention that consists in to change negative thoughts and into positive ones, fostering a good relationship with their babies. And this is the specific intervention that we are having in close to 500 mothers and babies.
I love this. This is so great to see. And I know that community health workers are a key part of this, right? And, maybe if you don't mind talking about their role and also kind of that bigger picture of how we have been collaborating with the Ministry of Health in addressing mental health concerns, because I really see a lot of integration between Socios and our government partners.
Yeah. In the majority of our intervention, we are working with a community health worker. We are small professionals, more community health worker. You can see in the next picture how we can interview in the communities with them, because they are very close to the community. And in the next picture, please, if you can see how we collaborate with the Minister of Health. We support in different activities, like to provide trainings or to include some guidelines across the country. And it's necessary because we need to go very close to the Ministry of Health, because the community needs more support. And Partners in Health Peru and Minister of Health always is working together. We include in the Community Mental Health Center and follow up all the people that are suffering with mental health problems. And I think that we need to continue in this work. We say nobody alone, all together.
I love that. Thank you so much, Carmen. This is really
Thank you.
impressive work in Socios. and you are such a champion there too. So thank you for joining us. I'd like to switch to Sierra Leone with Gonani here. Welcome, Gonani. I know also we have some slides to share too from your work. I think it was Beppy who shared that there was and remains one psychiatrist for the entire country. And we are working to counter that, right? Through residencies at Sierra Leone Psychiatric Teaching Hospital. But this before we get a bit deeper into that, I would hope you can provide us a bit of context of what it is like to live in a country for many people in Sierra Leone that our founder used to call acute unchronic trauma, right? This, years of poverty, talking about the history of the transatlantic slave trade and civil war and Ebola. Could you talk to that of the impact that has had on the mental health of many of the people you interact with daily?
Thanks, Leslie. Sierra Leone is a typical example of a country that has gone through a lot of traumatic and devastating events. At the back of the slave trade exploitation, you know that it has gone through 11 years of civil war that killed a lot of people. A lot of people were displaced, and a lot of people were left traumatized. We have got Ebola crisis, the 2014-15 Ebola crisis that killed a lot of people. We have had mudslide killing people within minutes. And all these, they have left really deep-rooted, significant mental health impact on the population. We have been seeing this in our various care delivery sites here in Sierra Leone, where a lot of people are coming in with different mental health, severe mental health conditions. When you dig deep, you find that there's an underlying trauma. You have people right now living in the streets, homeless, who are living with mental illness, and they need care. We have had a surge of young people using substance, and even the country was forced to declare an emergency on drug use. But if you look at the substance use disorder behind that, there's an ongoing deep-rooted trauma. So all these things are the impacts that I think this trauma ongoing, sitting on this country, has affected people overall. And despite all these, access to mental health services or psychosocial services is extremely limited in Sierra Leone. Baby has already mentioned that there's one psychiatrist working in the country against a population of over 80 million people. There are few mental health nurses working on the ground. And this has posed a challenge where partners in health, we have been working with the government to see how best we can work together to improve access, not only to severe people in severe distress, but also looking at even people in mild distress, substance use, and that. So that is a nutshell how this history has impacted people's mental health in the country. Yeah.
Thank you, Gonani. And here we're looking at some before images and after images of the Sierra Leone Psychiatric Teaching Hospital. So when we began working in the country in 2014, it was because of the Ebola outbreak, right? And now really digging in deep to other aspects of care and building the health system alongside our government partners. But can you talk to us a bit about the facility before, the conditions that existed, and now, and why that matters for patient care?
Great. So these photos, let's go to the previous slide, the first one. So these photos is just giving people a picture of like the Sierra Leone Psychiatric Teaching Hospital. We are calling it a teaching hospital now but this is the site where it was formerly called Kisii Lunatic Asylum or Kisii Hospital. Commonly, the mocking word that people are using was like a crazy yard. Before our support in 2018, this was almost like a place of abandonment. People were there dumping their relatives, were in chains, patients were in chains. There was no medications to support these people, no running water, no electricity. People were chained to their beds to carry a bucket to ease themselves. And no medications, very few staff that were there just to support the people who were there. And these are just showing the before on the left, and how we worked with the government. So the first point was to say that, okay, we have a country that I think we are still struggling to have mental health services, and we have a lot of people in severe distress. How can we transform this place to be a decent place? So the idea was to say, let's transform this place to be a decent place of treatment and rehabilitation, and work with the government to improve the infrastructure, as you are seeing on the pictures, to make sure that we have renovated the wards, the outpatient expansion of the triaging, the expansion of the laboratory pharmacy, and also restoration of water to make sure that I think there's available water 24/7, and also electricity. There was no medications, and we had to make that a commitment to say that we are providing medications, new generation medications, to treating these patients at the facility. And that transformation led to the expansion to establishment of the child adolescent unit, child adolescent services, for the first time to have a unit specialized on child adolescent unit, and also psychotherapy and occupational rehabilitation unit. And at the back of that, also expansion of the drug treatment and rehabilitation support. And we have been providing support to the staff as well, making sure that their staff at the facility to improve care at the facility. So over time, we have now seen the development of other initiatives, like, for example, in 2022, the government, after seeing this transformation, asked us to say, can we start training our own psychiatrists? We have only one psychiatrist in the country. Can we work on getting something on the ground to start training people in the country? And that is a commitment that we had to say that, okay, we are starting now a residency program. And it has been fully supported by PIH in terms of human resource, making sure that we have enough faculty members to provide training on the ground, and also providing online teachings where Baby, Stephanie, and other psychiatrists from Mass General, they are providing online teaching to the residents, and also providing scholarship support for the residents themselves, so that they can focus on this education, like, for example, registration, examination cost. And yeah, so in 2022, we got this 5-year accreditation to train these nurses. As we are speaking now, in next year, we're having 7 residents, and by the end of next year, we'll have 7 more psychiatrists adding to the 1 psychiatric on the ground. So this is a huge piece that melts my heart, because this is a significant step in the history of this country. Yeah.
It's so wonderful and heartwarming. Thank you for sharing that, Gonani. And I have one more question for you, and then we're going to open it up to everyone's questions. So please do feel free to drop any thoughts you have in the chat, and we'll try to prioritize that. But Gonani, you were just talking about the hospital located in Freetown, in the capital. I think one thing that I'd love to ask you about is this service now, the hotline, which I just think is wonderful. It's the nation's first hotline for the general public for mental health concerns. And this was, pushed out locally. And I'd love to know how the response has been so far. And have you seen more patients access services now because of this hotline, which really has nationwide reach? Please go ahead and.
Yes, thanks, Leslie. So after seeing Strengthen the Care at KC, it was an idea to say that, as Baby mentioned, that creating a continuum of care. And we had to go a year later to Kono, where we established this community-based mental health care model that is being driven through a task shifting model, like community health workers on the ground who are working on identifying and accompanying patients to care, making sure that the community is connected to the primary care facilities where they will be able to get the services in the communities, and also feeding it to the secondary facility where we have got mental health clinicians providing the care at the facility. So building on that community model, a continuum of care in Kono, from a secondary, primary to community-based, where we have counselors and psychosocial, community psychosocial workers. We still notice that I think the gap is still high, and that's where we move to a model to say that why can't we provide a helpline? So this 5116 was a helpline to provide care free of charge. A toll-free line is available 24/7. Is being run by the community, the psychosocial counselors and mental health clinicians. Basically, is a crisis response, providing counseling support to people in distress. Also, like the community members who are distressed in the community, as well, to be able to be supported whenever, like skills on how they can handle a crisis, a mental health crisis in their community, as well as also providing linkage to care and providing basic education. So this 5116 currently is 24/7. And once we launched it, we had almost over 150 calls coming in that month. And it was like a scramble to say, okay, how can we shape that? And I think from there, we have been building it up with also a strong team to make sure that is expanding. And the government last year, through the Ministry of Health, said that we have to launch it as a nationwide line. And so we're receiving calls from all over the country. And we have been trying to see how best we can continue to work with the government. And they have taken up, this government is, the line is part of the CUSH, the substance use crisis response line. So is one of the lines that is providing that support to the crisis that we have in the country on the substance use. So yeah, that's how far we have gone with that. Yeah, thanks.
Thank you. Thank you, Gonani, and thank you, everyone. And now we can turn to questions that you all have. And so I'll pull everybody back together. And maybe this is a question first for Stephanie and Beppy. We have a couple people, actually, both online here and then pre-submitted, just wondering about how we globally, not just Partners in Health, can address suicide deaths in a more effective way. And I'm curious to see, maybe Stephanie first, what, if anything, we are doing, and then, just a general thought behind that issue.
Yeah, thanks, Leslie. I mean, prevention of suicide is, of course, a primary goal in any mental health system development, which is what our primary endeavor is with our mental health team at PIH. And I would say that we, in our building of the continuum of care, and Beppy had mentioned the continuum from wellness to distress, I think we have a number of evidence-based interventions that are incorporated into that. One benefit to having non-specialist providers fully integrated into our mental health work is that you are broadening the cadres of people who can potentially recognize depression and suicide risk, particularly primary care nurses and people working in primary care settings, who are often the individuals who encounter people who are suicidal, perhaps more sometimes than psychiatrists or other mental health providers in the US. So our task sharing inherently, I think, really focuses on suicide prevention in that way, and that we are incorporating it across all of these different systems levels, and we're teaching and supporting and supervising individuals in treating depression and asking the questions and recognizing suicide risk and intervening, including reducing access to means if people are reporting suicidal ideation at any one time. And we also do engage in some policy. We just spoke today with our team in Malawi, where suicide actions are illegal, and so that's the case across multiple settings. And so we do engage in terms of trying to lobby for progressive policy change and to decriminalize suicide and suicidal behavior, so that we can move it into treatment rather than criminal behavior. And so we engage on that level as well. So it certainly is an area of import. And then fundamentally, as we're trying to reduce the burden of illness, particularly with depression and substance-related disorders, which put people at higher risk, our work in trying to engage and reach a broader range of the population who are suffering from those problems, I would say, is one of our primary interventions for suicide prevention.
And Carmen, it looks like maybe you want to add something there. I saw you go off mute. Oh, you're muted again, unless that was intentional, which is also fine.
Sorry, I want to add that in Peru we are identifying the increase of cases of suicide in teenagers, and we are working with different activities and how we can to approach the teenagers to different activities. We are using the technology, for example, because it's necessary to be more close to adolescents, and we provide education, we provide self support, and in case if it is necessary, we share with the Minister of Health with some activities, because we need to integrate the adolescents to the good community. And in another plans, we include our work in the schools, because it's necessary to maintain more good relation with the co-pairs, with our peers, with the teachers, and with the caregivers. But I think this is the process, because in Peru, we are having gaps yet, but we are trust that in the next months we will have more resources for obtain more activities in teenagers, in adolescents.
Thank you, Carmen. There's another question, a couple questions, Gonani, from your presentation. Salvador wanted to know, what are some of the main substances of abuse in Sierra Leone? And then another listener on YouTube, Louisa, asked, can you give us a little insight on what people are calling about on the hotline? So maybe if you don't mind addressing those.
Thank you, Salvador and Lisa. So the commonly used substance is called Kush. So Kush, we are still trying to find out what it is, but it seems it's a concoction of different substances. So fentanyl is there, they are adding human bones, they are adding formalin, they are adding different things. So they are getting human bones and everything combining. So you find that it's called kush, but there are different combinations in that. So that's the commonly used substance currently that is sweeping the youth of the country, and we are currently in a crisis. Yeah, so, and from, sorry, the question from the issue.
Yes, and Louisa was interested in knowing, what do people generally call in about for the hotline? Do you have any examples of issues that they bring up?
Yeah, so a lot of people are calling in because they just need to talk to someone, and a lot of people, they just have, we had like an evaluation that was done 4 months ago, and a lot of people were just calling to say that we need to talk to someone, and there are some things that are really stressing themselves. So they are calling for their own support on how they can handle that. And few of them, they want to have enough time and they call at night, especially, and they'll stay long on the call, talking to someone on the call about it. And secondly, is people like looking for support. They have identified people in a crisis in the community, and they are calling in to say that how best can we handle this person is doing the following things. How can you support, and how can, so seeking like point of how they can support that person, and how they can access a continuum of care in there. And that is an area also that we are still working with the government, because we are receiving calls from almost across the country, and in other districts still they are we don't have services on the ground. So looking at creating those kind of pathways, that's an area that is ongoing, and we are working with the government to see how best we can work on that. Yeah, thank you.
Thank you, Gonani. And the next question, maybe Beppe, if you would like to address it first. This was actually pre-submitted, and then another submission. It's related to culture and mental health care, right? And I think we often get this question too, working in many other countries, right? Is posed this way: anthropologists recognize that concepts of mental health may vary across cultures. In your program, is there an effort to recognize possible cultural syndromes that maybe involve apparent beliefs and behaviors, but are normal within a culture? What do you think, Beppe, and anyone else, I guess, to add on?
Yeah, it's an important question, because there are reasonable concerns about sort of exporting Western models of care. And, depending on the context and the country and the local context, one has to know and think about a number of sort of historical and cultural factors. I mean, the first thing to think about vis-a-vis our work is fundamentally that we have our clinical care is led by local community members and local team members who are familiar with the culture, and who take the lead on sort of designing the clinical care package and how it intersects with traditional healers and other local healing practices. Depending on the context, we have to think about culture, we have to think about race, we have to think about history. And, the history of psychiatry during colonial periods, there are different colonial histories that have manifested in different ways where we work. And then there's the post-colonial context. And then we have to also consider what have local responses already been prior to Partners in Health's engagement. What have local responses already been to those colonial histories of the way mental health care was delivered? There's a field of the mental health care professions called ethnopsychiatry. And in the colonial periods, ethnopsychiatry was sometimes used as an instrument of control. But there have been local responses to that history that are important to pay attention to. There are rural-urban dynamics, and there are other dynamics that we attend to. So to answer your question, because you mentioned research in the question, PIH is not a research organization. We are a care delivery organization, but we use sort of targeted research, the questions generated by our local teams. And Carmen, for example, is getting her PhD. Gonani, for example, has a master's in global health delivery. And so our frontline team leaders, they have delivery skills, but they also have research skills to use qualitative and quantitative methods to answer questions. So an example I'll give is that in Haiti, after the earthquake of 2010, we started to articulate a sort of this decentralized model of care. Zanmi Lasante had already had mental health embedded in HIV and TB care. And the local team, through qualitative research, decided that depression care was where they wanted to start. And so we developed and validated a depression screening tool through interviews with voodoo priests, with local leaders, with local providers. And so we've used targeted research to develop these kinds of tools to better assess and diagnose, but to have local people making those decisions, which are really individual, person-centered decisions about what a diagnosis might be. And hi, Phil, I saw your question about the DSM. I mean, our frontline providers use the ICD-10, they use the DSM, but fundamentally our frontline providers are well positioned to determine diagnoses as best they can. And then in general, in mental health, we think about the ways that different disorders travel together. But we feel that our frontline teams are well positioned to take a careful approach to clinical care delivery.
Thank you for that. And I'm looking at time and being mindful here. I know we have many questions coming in, so thank you all. I think one theme that is emerging is it's wonderful to train psychiatrists, and clearly there's a need, but many times the front line, right, is not necessarily at that level. So how, maybe Stephanie, if you could talk about this broadly, and then Carmen and Gonani, how do we recruit people to do this work in mental health? And, you know, another question was, many of these folks are volunteer. You know, how do you support that? But I know that's not necessarily our model. So maybe Stephanie, if you don't mind, and then we could pass it along.
Yeah, we certainly advocate for payment and support of all of the people who work within our systems, from community health workers to other non-specialists, and building in support and supervision for them, because it's certainly the case that we can't just train up community health volunteers and turn them off into wherever from whence they came, and expect that we have then created a model of care that is going to be effective and be able to demonstrate impact. And so we focus on, how do you effectively support people at all levels to engage in the ways that it makes the most sense at that level? And how do you parse out these tasks that perhaps in the United States have been often in the basket of psychiatry, psychology, social work? How do we parse them all out to make sure that they're covered, but also that people can be supported and paid for their work? And so that is certainly something that we advocate for. It's not to try to do things as cheaply as possible by just using volunteers. So that is certainly our model. And then, you know, with the goodness of fit in terms of mental health care, I mean, there are many people who are very drawn to mental health care, including community health workers, and some for whom it's not a great fit. And we do try to recognize when people are engaged and interested and want to continue and offer professional development paths and ways that they can engage in mental health care if they feel it's suited for them. And it's not about trying to recruit everybody and anybody and kind of push it into their plate, but that we do try to identify who feels motivated and compelled to work in this area, because there are very many, and many have not been offered opportunities because they haven't been there. And so that's one thing that we try to accomplish. And I can also have Carmen and Gonani respond, who work directly with community health workers every day.
Yeah. Yeah, in Peru, we are working 20 years ago with community health worker. We identify the people that are living in the community, very close to our patients, to our people that are suffering. And in the first year, we started with tuberculosis, but we provide mental health support too. And year by year, we are working with them. We provide training. We provide more knowledge about how we provide more help in mental health and more support in mental health. And yeah, we organize different groups. We have community health workers that provide support in clinical activities, and we have some community health workers that provide emotional support or screen with some tools some problems in mental health. But we are choosing, we are provide training, we are asked to them what is the best option that they are want to have in our institution in Partners in Health. But I think it's necessary time. It's necessary to communicate more with them. It's necessary in some case to change to an area because in some months they are working in clinical aspect, in another moments, in another month they are working in mental health. No? But I think this is a process that we are having in Partners in Health Peru.
Mm-hmm. Thank you, Carmen. And Gonani, also just a thought of, how do we incorporate that at all levels, including psychiatry, right? Sierra Leone.
Yeah, exactly. So I think we are still using the people living in the communities to be recruited as community health workers, and they are salaried, and to focus 100% on their work. And to respond also to the question about psychiatrists, we are looking at creating that workforce alongside the continuum of care. So you are looking at, for example, KC as a tertiary facility, and you are looking at secondary facilities, district hospitals, and you are looking at primary facilities. So we know that in the spectrum of people being in severe distress, they will need this severe kind of support that they will need through the specialist care. And when you are going down to the community, you train people to be able to identify and be able to support using other means like psychotherapy and other services. So we are looking at this, for example, like the psychiatrists we are training in the country. They will help not only in that, but also you are creating a leadership kind of model, because it's you need these services of mental health in the country to have that kind of leadership. So training them apart from hands-on, but you are creating also an army of people who can be able to provide leadership oversight and to the delivery and continue to build the mental health services in the country. So yeah.
Thank you so much. And I see that our time is now up. An hour always goes by too fast when I get to talk to all of you. But I really am so grateful to all of you, Bepi and Stephanie, Carmen and Gonani. I know this was really a wonderful conversation for everyone. I wish you all a wonderful World Mental Health Day. Please take care of yourselves and have a wonderful rest of your day and week. Thanks again, everybody.